Hello, my name's Nate, and today I'll be talking about the pharmacology of Danicopan. Danicopan is a factor D inhibitor. It's used for the treatment of paroxysmal nocturnal hemoglobinuria, abbreviated PNH. Okay. PNH is quite a simple disease. The paroxysmal stands for sudden and recurrent. The N, nocturnal, stands for night. Hemoglobinuria is a sign of an underlying disease, and it stands for blood in urine. Okay. Why would you get blood in your urine? Well, you get blood in your urine because your red blood cells are being destroyed. That's what we call hemolysis. Heme blood lysis, destruction of those blood cells. RBC, red blood cell destruction. Actually, yeah, we can talk about it. So hemolysis is actually further categorized into extravascular hemolysis and intravascular hemolysis. These two terms are important for understanding why Danicopan was approved on top of current mainstays of therapy. And the extravascular hemolysis stands for red blood cell destruction outside of your vasculature or outside of the red of your arteries and veins. And intravascular means within your circulation. So what are some of the signs and symptoms of PNH? There are three notable signs that you will see in these patients. Number one is fatigue. So anytime you lose blood cells, you're going to experience fatigue. Also going to experience anemias. So that's the reduction in RBCs or red blood cells. And lastly, these patients will undergo thrombotic events, which is essentially clots. When these clots form in major vital organs, such as your lungs, your heart, or your brain, you could get pulmonary embolisms, you could get heart attacks, or you could get strokes. Thrombosis is the reason why patients are admitted and why patients die from PNH. Chronic fatigue is going to be the most common symptom. So, let's go into the pathophysiology of PNH and why a patient would suffer from it. So, let's draw a little red blood cell here. So that's my happy-go-lucky red blood cell. Red blood cells and all cells in your body have a gene called PIGA. Okay? PIGA is conserved up the cell lineage, so hematopoietic stem cells will have this gene coding for a protein called GPI. Okay? GPI is a transmembrane protein, and it serves as an anchor for extracellular proteins expressed by these cells. Two major important proteins that we're going to be looking at today are CD55 and CD59. Okay? CD55 stands for decay accelerating factor. CD59 stands for membrane attack complex inhibitor protein. To understand these proteins, I'll go into the complement system and what causes hemolysis. Well, first, let me just get this down. It's caused by a mutation in PIGA. Okay, that's what causes PNH. A mutation in PIGA, so these red blood cells can no longer have a functional GPI protein anchoring the surface proteins CD59 and CD55. Therefore, these red blood cells will be attacked and undergo hemolysis. So let's go into how these red blood cells are attacked, causing PNH. For that, I'm going to use a red marker. Let's talk about the complement system for a second. I like to call it the complicated system because it's quite complicated. It's part of our innate immune system, however, it branches into the adaptive immune system. And it's primarily part of the innate system because unlike the adaptive immune system, it has sort of a primitive method of recognizing self versus non-self. So if you've taken an immunology class, you'll know that the adaptive immune system is very specific. Your T cells will target pathogens with a specific antigen or a protein on their surface, and that way they will know that that is the pathogen they are targeting and not the self, its own self or its own cells, right? However, the complement system uses a different method. It will destroy and attack everything. However, it marks its own cells to prevent the complement system from attacking them. So some of these proteins include CD59 and CD55. So if you have dysfunction in these proteins, complement system can no longer recognize self versus non-self and will just start attacking its own cells. And in the case of PNH, when it starts attacking its red blood cells, you're going to get hemolysis. All right, let's talk about it. So the complement system is composed of 3 pathways: the alternative pathway, classical pathway, and leptin pathway. Essentially, these pathways are modes of recognizing danger or non-self, and they all converge at what is called the C3 convertase. Okay, I'm not going to go into anything upstream of the C3 convertase because we don't need it for today's discussion, but the C3 convertase converts C3 into C3b and C3a. Okay, pretty simple. C3b has 2 fates. First fate is it can combine with the C3 convertase, okay, to generate the C5 convertase. C5 convertase, similar to the C3 convertase, takes C5, converts it to C5b and C5a. Now C3a and C5a are considered anaphylatoxins and are involved in anaphylaxis. We don't really care about them for today's discussion. But what we do care about is C5b. So C5b will combine with C6 through C9 to generate what is known as the MAC complex, membrane attack complex. Draw it out right here for you. So that's your MAC. The MAC complex will embed itself into cell membranes, for example, red blood cells, and encapsulated bacteria, and cause osmotic lysis via expulsion of its contents. Okay. C3b, like I said, has another fate. C3b can be converted into C3d, also known as an opsinin, which can be found on your red blood cells and pathogens. So it will be deposited on these cells and essentially act as a molecular target or a molecular marker for macrophages and cause them to undergo phagocytosis. So that process, opsonization, C3d acting as the opsinin. Macrophages, when found in the liver, called Kupffer cells, will generate phagocytosis, leading to destruction of your red blood cell or pathogen, on top of the destruction via MAC. Now, where do these 2 proteins come in? So, decay accelerating factor, CD55, found on the surface of self, so red blood cells, inhibit C3 convertase, thereby inhibiting C3b production. If you don't have C3b production, you don't get opsonized phagocytosis, and you don't get membrane attack complex mediated osmotic lysis. Additionally, CD59, found on the surface of your red blood cells, inhibits the formation of MAC. The MAC is the main effector function of the complement system and is what we want to be preventing when we talk about PNH or hemolysis. So a couple years ago, we had a very lucrative drug come out called eculizumab. A few years later, an improved version of that drug came out, but they essentially do the same thing. Wrote that wrong. Sorry. Called ravulizumab. Okay. You probably heard of this brand name, eculizumab solaris. Both of these proteins, these monoclonal antibodies will inhibit C5, preventing C5 convertase from generating C5b. These two drugs were specifically developed to target C5 because they wanted to prevent complications of bacterial infections. If they went any further up on this cascade, they would essentially be inhibiting opsonized phagocytosis of pathogens. Right? They're already preventing MAC-mediated lysis of these pathogens. If they further prevent the opsonized phagocytosis, these patients will have severe risk of infections, specifically by encapsulated bacteria. So this was well and dandy, except for a couple years later, doctors started realizing that these patients, although they were having very well-controlled blood panels and their hemolysis was under control, they still had some sort of upregulation of thrombosis and some anemia, and they still had a few symptoms of PNH, and they were questioning, why are these patients still having hemolysis if we're preventing MAC-mediated lysis? The answer was actually the C3b-mediated chemolysis. And they realized this because they found that patients treated with eculizumab and ravulizumab that had PNH actually had an increased C3b deposition on their red blood cells. This makes sense because these patients with mutations in CD59 and CD55 had no breaks on the C3 convertase and increased, I'll write it in yellow, increased C3b, right? However, if you're preventing your C5 convertase from taking the C3b, all that C3b is then going onto red blood cells for hemolysis, and you're going to have increased what they termed, I'll write it in green, what they termed extravascular hemolysis. Therefore, this was termed intravascular hemolysis. So they were preventing intravascular hemolysis, but they found complications of patients treated with these medications had extravascular hemolysis. That's where Danicopan came in. Danicopan, as I said, is a factor D inhibitor. Factor D is responsible for the creation of the C3 convertase via the alternative pathway. So we'll take C3BB, liberate BA to generate the C3 convertase. And your Danicopan prevents this from happening by inhibiting your factor D. Therefore, you're inhibiting your generation of the C3 convertase via the alternative pathway, and thereby reduction of C3b. That is not to say that all the C3b will be depleted in your bloodstream, as you still have classical and leptin pathways generating C3b. So Danicopan was approved on top of eculizumab and ravulizumab to treat paroxysmal nocturnal hemoglobinuria.